I would like to thank Sina Coldaway, Stephen Simpson, and Sonia Labo for taking part in this section about sepsis and infection in ICU. Sepsis is a medical emergency and can develop rapidly and have devastating consequences for the patient, which can lead to organ failure and even death. Sepsis is a serious and severe reaction to an infection where the immune system becomes overactive and starts causing damage to the body itself. Here are a few key messages to take out of this session. To start with, we need to think who is at risk. And at risk are people who are over 75 years old, who are frail, patients who had chemotherapy recently, so this would be what we would call neutropenic sepsis, people who had surgery or invasive procedures in the previous 6 weeks, people with impaired immunity, such as diabetes mellitus, a breach of skin integrity, for example, when a catheter has been inserted or a cannula, people who are dehydrated. Something that we might not consider very often is women who had given recently birth or had a miscarriage or had their pregnancy terminated. And there are people as well who are at high risk who are misusing intravenous drugs. As it has been mentioned in the presentations, ICU patients are particularly susceptible to infection because of their impaired immunity, the invasive medical devices which are used, and not to forget that there are a lot of antibiotics which are used in ICUs, and these are environments with drug-resistant microorganisms. Stephen Simpson presented the signs and symptoms of sepsis, and he used the acronym sepsis, and that is more related in the community. For example, S stands for slurred speech or confusion, extreme severe non-muscle pain, passing no urine in a day, severe breathlessness, it feels like you're going to die, and skin mottled or discolored. These are the general signs and symptoms that would make somebody to seek immediately help. Temperature is one of the common symptoms in sepsis. However, it's not the only indicator of sepsis. There are patients that they are septic but do not always have a high temperature. The National Institute for Health and Care Excellence in the UK has developed quality standards in terms of the assessment, treatment, and management of sepsis. Within these quality standards, they are talking about 3 levels of risk criteria. So we've got low risk criteria, moderate to high risk criteria, and high risk criteria. I'm sure that in your countries, you probably have similar guidelines from national institutes or organizations or even charities around sepsis. I will mention the high-risk criteria, which are more related in ICU, just to remember what these might be. So, a change in behavior when there is evidence of an altered mental state, heart rate, which is increasing and it's more than 130 beats per minute, respiratory rate, which is above 25 breaths per minute, or when there is a need for 40% oxygen or more to maintain saturations more than 92%. Obviously, we might have chronic obstructive pulmonary patients, and then the saturation level should be around 88%. When systolic blood pressure is 90 millimeters of mercury or less, or when it is a different blood pressure, for example, more than 40 millimeters of mercury below normal. Another situation where sepsis is a high risk is when the patient has not passed urine in the previous 18 hours, or for catheterized patients when they pass less than 0.5 milliliters per kilogram of urine per hour. The skin is looking mottled, or the patient has got an ashen appearance, and there is cyanosis of the skin, the lips or the tongue, and non-blanching rash of skin as well. These are the high risk criteria for sepsis. In terms of assessment, the general approach is the ABCDE approach. So we're using and we are assessing the airway, the breathing, the circulation, the visibility, and the exposure. And as Sonia mentioned, we have to observe for localized signs or symptoms of infection. For example, the entry of the cannula on the skin, whether it looks infected. We have to record the observations, and if in your country you've got early warning systems, these are scoring clinical observation tools, then use them and to identify and justify your decisions. In terms of management, the first hour of sepsis is critical. Every hour that passes increases the risk of dying. There are 6 actions which are taken when sepsis is diagnosed, and these are generally oxygen to keep saturations above 94%, or as I mentioned earlier on, if we're talking about chronic obstructive pulmonary disease patients, then that should be between 88 to 92%. Blood cultures are taken. We give intravenous antibiotics, and that would be the maximum dose of a broad spectrum antibiotic. Then there is a fluid challenge, and for adults that would be approximately 20 mL per kilogram. It's usually the lactate which is guiding further fluid therapy, and lactate is produced during anaerobic energy production. So the higher the lactate, the more difficult the situation is, and it has to be the oxygen levels of the patient have to be considered as well, the saturation. Blood lactate are mentioned, and then finally is the urine output to monitor the urine output. We have to ensure as well that the senior clinician attends the situation. Finally, the biggest message I think comes from Sonia, and it has to do with prevention of infection. This is paramount because half of health-associated infections are preventable. So I will remind you the 3 main issues that Sonia mentioned. Insert medical devices only when essential, and then the techniques we're using, they have to be sterile and aseptic. We have to maintain carefully and avoid all unnecessary and unessential manipulations of these devices, and they have to be removed as soon as no longer essential. Another message that came up from Sonia's presentation is to speak up. So if you feel that aseptic techniques or sterile techniques are breached, then speak up. Say that something wasn't done right, because you can save someone from developing an infection, and that infection could lead to sepsis, and then further down it could become septic shock, which could put a patient's life in danger. So speak up, and finally make sure that you maintain hand hygiene and wash your hands carefully. Thank you very much for attending this session, and I hope that you have taken quite a lot of messages out to help you when you are looking after patients in ICU.